Hey, future nurses! Welcome back to NCLEX-bay. Today, we are conquering the ultimate masterclass blueprint on adult integumentary disorders and burn management. Let's dive straight into the high-yield facts you need to master. Here's our masterclass agenda for today. We're covering skin basics and wound care, high-yield skin infections, bites, stings and frostbite, skin cancer and chronic conditions, burn care priorities, and we're wrapping it all up with the high-yield quiz. Section 1. Skin Basics and Wound Care. Let's get right into it.
So the integumentary system is literally your body's first line of defense. Remember these board favorites. Normal skin pH sits right between 4.2 and 5.6. That slightly acidic environment is absolutely crucial because it halts bacterial growth. Now, if you're getting a skin biopsy or a viral culture, here's your golden rule. You have to place viral cultures immediately on ice. No exceptions. And always obtain your cultures before you start any antibiotic therapy. You also need to know your 5 types of wound exudate inside and out. We've got clear serous, pink serosanguineous, red sanguineous, full-on hemorrhaging, and then infected, thick, purulent drainage. Know them cold.
Section 2. High-yield skin infections. Let's look at a classic test trap, cellulitis versus erysipelas. You really have to differentiate these two by their anatomical depths. It's kind of like a layering game. Cellulitis goes deep. We're talking an infection of the dermis and the underlying hypodermis. Erysipelas, on the other hand, stays a bit higher up, involving the dermis and the lymphatics. Examiners love to test if you know exactly where that infection is living, so lock that visual in.
Next up, shingles and MRSA protocols. For herpes zoster, which is shingles, the virus acts like a sleeper agent that reactivates in the dorsal root ganglia. If your patient has vesicles, you are putting them on strict contact isolation. Keep them comfortable using an air mattress or a bed cradle to keep the sheets off those painful lesions. Oh, and you must start antivirals within 3 days of the rash appearing to prevent severe nerve pain. As for MRSA, your screening heavily relies on a nasal swab. And just like shingles, strict contact isolation is an absolute non-negotiable.
Section 3. Bites, Stings, and Frostbite.
Let's talk environmental emergencies, because these protocols are literal lifesavers. Got a brown recluse spider bite? Apply intermittent ice for 4 days to slow down that venom's enzyme activity. For bees and wasps, gently scrape the stinger away. Never, ever use tweezers. You could pinch the venom sac and squeeze more venom right into your patient. For snake bites, focus on safety and rest. Remove tight clothing, keep the extremity below heart level to slow the venom spread, and whatever you do, no ice and no incising the wound. Finally, for frostbite, your protocol is rapid rewarming in a warm water bath between 104.0 and 107.6 degrees Fahrenheit. And listen carefully, no dry heat and absolutely never massage frostbitten tissue.
Section 4. Skin cancer and chronic conditions.
Let's tackle a few chronic conditions. For psoriasis, you're looking for those classic silvery white scales on raised red plaques. You absolutely need to know the Koebner phenomenon. This is when psoriatic lesions develop right at the site of a physical injury, like a scratch or a sunburn. Shifting to skin cancer, keep in mind that melanoma is highly metastatic. It spreads quickly to the brain, lungs, bone, and liver. And we can't forget Stevens-Johnson syndrome, or SJS. This is a severe medication-induced emergency, and it's very often triggered by sulfonamides or NSAIDs. Let's quickly hit pressure ulcers. Stage 1 is intact, non-blanchable redness. Stage 2 is partial thickness loss. Stage 3 digs into the subcutaneous tissue, and Stage 4 exposes muscle or bone. But here's the massive safety guardrail you must burn into your brain. Never massage a reddened skin area. I mean it. Massaging can damage those fragile capillary beds and cause irreversible tissue necrosis.
Section 5. Burn care priorities.
Okay, we're in the critical care zone. You need to memorize this exact 6-step priority sequence for burn care. Number 1. Assess airway patency. Number 2. Administer oxygen. Number 3. Obtain vital signs. Number 4. Initiate an IV line and fluid replacement. Number 5. Elevate extremities, assuming there are no fractures. And number 6. Keep warm and NPO status. For that fluid resuscitation, we use the Parkland formula. And here is a huge NCLEX tip. Opioid analgesics must be administered via the IV route only. Why? Because absorption from IM or sub-Q injections is completely unpredictable and dangerous during massive fluid shifts. Also, just a quick reminder, an eschorotomy relieves pressure from restrictive eschar, but a fasciotomy goes deeper to relieve actual compartment syndrome.
Section 6. The high-yield quiz.
Time to see what's stuck. Question 1.
What is the priority nursing action for a client who just sustained a snake bite to the lower leg? Is it A, apply ice to the bite, B, incise and suck the wound, C, rest and keep extremity below heart level, or D, apply a tight tourniquet? Think about what we just covered.
The correct answer is C, rest and keep extremity below heart level. By doing this, you're slowing the circulation of the venom back to the core. And remember, never apply ice and never incise that wound. Let's hit question 2. A client comes in after exposure to poison ivy. What is the immediate nursing intervention? A, apply topical corticosteroids. B, clean the skin of plant oils immediately. C, apply a warm compress. Or D, administer oral antihistamines. Lock in your choice.
If you guessed B, you nailed it. Cleanse the skin of plant oils immediately. Immediate cleansing removes that nasty uracil oil, which is the exact culprit causing that severe papulovesicular dermatitis. Wash it off right away.
Question 3. How is cellulitis anatomically defined? A. Inflammation of the epidermis only. B. Infection of the dermis and lymphatics. C. Infection of the dermis and underlying hypodermis. Or D. Deep tissue infection of the muscle. Think back to our comparison slide.
And the answer is C, infection of the dermis and underlying hypodermis. Cellulitis dives deep into that hypodermis, whereas erysipelas is specifically targeting the dermis and the lymphatics.
Moving to question 4. Which clinical finding indicates an improvement in a client being treated for psoriasis? A. Decrease in silvery white scales. B. Appearance of the Koebner phenomenon. C. Development of purulent exudate. Or D. Formation of clear, fluid-filled blisters.
The right answer is A. A decrease in those classic silvery white scales proves your treatment is working by reducing skin cell proliferation.
Last question. Let's bring it home. Which diagnostic test is used to definitively identify the organism causing herpes zoster, also known as shingles? A. Zinc smear. B. Dioscopy. C. Viral culture. Or D. Wood's light examination. Watch out for the trick here.
The answer is C, viral culture. A viral culture actually identifies this specific organism, while a Tanzac smear just tells you there's a general herpes infection floating around. How did you do on this challenge? Drop your score in the comments below. Save this video, share it with your study partner, and follow NCLEX-bay for more. See you in the next masterclass.